Aha.
Thank you very much for that talk. We have a bit of time now for some Q&A. And so we have people participating online as well. So if anyone has a question that you would like asked, such as this one right up front, and we've got a microphone coming here.
Thank you. This is really great. And I didn't even know pelvic pain existed as a problem until about 2 years ago when a client came in. So people don't always tell you that they've got it. So I don't know very much, but one of the things I'm curious about how it fits into this whole picture is interstitial cystitis, which I understand is like a chronic inflammation that's hard to treat because it's not really in the cells. So how does that fit into all this?
They're kind of going, they being those who make names of things, are going to the, help me out here, I just forgot it.
Bladder pain syndrome.
Thank you, bladder pain syndrome. Because interstitial cystitis is supposed to be inflammation of the lining of the bladder, except for it's often diagnosed as that and there isn't any inflammation. So they switched the name of it, and the organs hurt too, sort of. But we're all alive. It tends to be a diffuse pain. So what can we do about it? Help them positively cope, avoid triggers, but still have a life, and not be afraid to move. Because if you've ever had a UTI and you want to go run and it feels like your bladder's bouncing from your neck to your toes, that's a very uncomfortable feeling. If you walk around like that every day, they tend to not move, which makes everything worse.
Thank you. We have another question here off to the left.
Alice, you beat me to it. So I can ask my second question. I often hear chronic bladder pain talked about in the same context with other chronic pain conditions like irritable bowel syndrome, chronic fatigue, and fibro. Mm-hmm. And I'm wondering what I guess I'm wondering two things. One is, what's your opinion about that? And two is, when you have people who live with these long-term chronic pain things, especially when every day is a new adventure and you don't know what's going to hurt most from one moment to the next, I'd like to hear more about your perspective on, I wrote it down, but I can't find it now, on making things interesting and fun for both client or both.
In a definition of a life that is pretty much sucking at the moment?
Yeah, that's pretty, yeah.
That's how I talk. It's tough. And that's where I go back to what can you do in 5 minutes today that is, even if it's not great, at least is less bad. That might be where we have to start. And then try and expand from that. So in those kind of diffuse and long-term conditions, one, you're part of a team. So there's a physician that's following them. There's a lot of other things. All of the pelvic health issues tend to have a lot of centralization around it, just because it's scary. Not to minimize it at all, but there's, like with ICS, it's when you know that you can't eat anything because you're going to hurt, because that's been your experience for the last 12 years. It would be very interesting if we could have someone eat and not know they were eating, because then you could see if that really was true. But there's all of that expectation and learned responses and things that our very clever system will inflame something because you looked at food. Hard to separate that out. So we just do education, get them doing fun things, get some mindfulness. It's a complicated process, but it is changeable. And as Bronnie said so beautifully earlier, we're not going to tell anyone they will be out of pain, but we can help them to cope and to have a life, even when it seems like everything you've been told is you just have to give up everything you love. That's really not fun. And that's, again, why I like the PCS, because talk about hopelessness is if you looked at the ICS diet, my goodness, you get like water, lettuce maybe.
We have a question from one of our online participants.
This question comes from Brian Rutledge. Can you give an example of offering evidence around a current belief where the belief was recently provided by or reinforced by another healthcare practitioner which your patient is working with? Also, there's an additional question. As a massage therapist, how would you suggest we do so when the other provider is considered by society to the patient to have a greater degree of authority and knowledge?
Asking for a friend. That's hard because as professionals, we want to act like professionals. We don't want to say, well, they're a jerk, so just ignore them. Don't say that. Because guaranteed, don't say that, because you're going to be the one that... So one way, if you've got that situation, the best thing to do is talk to the other professional so that the patient doesn't end up in the middle. But also talk to the other professional, because I know there are people out there that think that I told them things that I swear I did not say. And that happens. So I want to try, I will get cranky when those situations arise, but I try and remember that what that person told me that they heard might not be what that person said. So you want to check. And then I forgot the other part of that. How do I evidence against something? So like someone comes in, and I have have had people in the past, I'm HIPAA scrubbing this. So a guy who was told that his pain was because he had an anteriorly rotated pelvis and a leg length discrepancy and a rib out of something, and all of these very biomechanical things by someone that they trust greatly. I choose not to call that out. I try and work within that framework without saying words I know are wrong to get them into a better place. It makes it really hard, and that's why I want everyone to be really good at pain science so I don't have to do that anymore.
We had another question in the back row.
The winner of all the books.
And then the next question will come from over here.
I'm asking on behalf of a friend who, she was while giving birth to her son, she suffered a hernia that has produced a consistent sensation of pelvic pain, and she asks, since insurance won't cover an MRI if a hernia is not sticking out, how can one figure out if a female patient has an occult hernia, aside from landmarking the typical pain pattern? The patient says there is a slight bulge, a pea size, that comes and goes near menstruation, but not every cycle. It's random.
I am very surprised that I have an answer to that is sensible, because normally I would say not a physician, not going to go there, but real-time ultrasound can be very helpful, and there are many pelvic health therapists of assorted types that have that skill and training, and physicians that are OB-GYNs and such that have that skill and training to be able to do that, and it's done in the office. So I would say that. Do my brilliant pelvic health therapists in the back of the room have anything else to say?
My comment was that's not how hernias behave. So I would also, even though the patient feels like that's what she has, I would probably explore that a little bit more and see what else is going on.
And tend not to be cyclical with your period.
Right.
But I would defer to a physician at that point.
I would certainly, I think anytime you need to look at getting credible evidence that the tissues are healthy. And if you have that evidence, then there's other things that you can look at. Maybe some tissues are tight, or there's some things that are weak, or again, that central pain mechanisms may be creating some problems.
Also, if her primary complaint
these are the pregnancy people in the back. I am not a pregnancy person.
If pain is her primary complaint, I mean, we've spent a fabulous couple of days talking about how structure and anatomy and mechanics might play into it, but also might not. So even that belief that the hernia is the thing causing the pain, I'd encourage her to find a really good pelvic floor therapist who knows her pain science or his pain science, and to have that evaluation and see if they can make her have less pain and discomfort in spite of the fact whatever hernia may or may not be going on hasn't yet been addressed.
And that's the best thing. What do you do when you want to figure out what to do? That would be my team.
So our next question comes from the front of the far side of the room.
Hello, Sandy.
Hi.
Great job. I just had a quick question. Many of the patients that I think maybe quite a few people see have multiple areas of pain. So we may have pelvic pain, but we also have low back pain, a lot of stress and tension. Many of my patients hold a lot of tension, like through their paraspinals, for example. And so in order to kind of change that neurotag, so to speak, I want to try to get them to activate their abdominals or their core. And sometimes I don't want to create harm if there's at risk of creating more tension in the pelvic floor. And was wondering if you could answer, is there a way to kind of determine when we should shut it off, or is it okay to turn it on?
Can I rephrase that and you can tell me if I got it right?
Yeah.
So you wanting to know essentially how to safely get movement through the pelvic floor in a way that's not going to create more spasm if it's there.
Perfect, yeah.
Excellent. Yes. You're not going to let me get away with that. So if I had a
Core
person that I
and
was worried about that,
transversus
because the question is, how do you know?
Right.
You know, how do you know if you guys make a fist, you know you're making a fist, and you could look and check in case for some weird reason you couldn't feel your hand anymore. But if you're clenching your pelvic floor and you've done it for so long it doesn't even feel clenched anymore, it might feel normal. And you could be saying, relax your pelvic floor. And they're like, yeah, I am. And an internal assessment would say, no, you're not, because we can feel it. So sometimes
which I'm not doing.
Well, we can team up. Sometimes that's helpful. The real-time ultrasound, you can see it. But one of the quickest ways to biologically get your pelvic floor to relax is to get into a nice deep squat if you can. If you can't, get on your back, put your knees up like you're in a squat, but that way. And it opens up the spaces a little. It's not going to do that to it. Just take some pressure off so we get to use the physics. And then diaphragmatic breathing. And you can put them in a place where they are most likely less tense. But then you want to grade that back into where that they can jump, like Greg was jumping off the stage, and those loaded environments, and have it be able to contract and then relax again, because that's normal. So probably have to assess it and then come up with a plan that addresses it. But if it's been tight for a long time, people don't usually know. And sometimes it's not.
Yeah, I find I do a lot of core with my patients, just to kind of try to get them to relax their back. So I don't want to do harm by creating more tension through the pelvic floor.
We don't know if there is more tension there.
Right,
and the system is made to so that we don't pee on ourselves, which is convenient, to when you increase interabdominal pressure, that's met by increased force in the pelvic floor. So you don't want uncontracting, that's not a word, pelvic floor when there's force up above it. So there does need to be that. There's some really cool stuff you can do, but find a pelvic health therapist near you.
We do have another either question or comment to come in the back of the room. But while the microphone's heading over, just you said there's something that you said in a conversation that we were having yesterday about for simple home exercises that somebody could do if they've been having a lot of sensitivity.
Yeah.
If you could talk a little bit about the example.
I think last night I was talking about sitting on one of those therapy balls because the ball is round. Because when you sit on there, you get, and sitting is comfortable, you can get the pelvic floor to relax down onto the ball. You can get some of that sensory awareness. So just sitting on one of those therapy balls and moving around, kind of fidgeting, like I tell my patients to pretend they're 4 and just play.
Could you clarify what you mean by therapy ball?
The big round ball.
Okay.
That one right here. Okay. It's blue. You can get them at Target and all those places. What the rule of it is that when you sit on that, your knees should not be higher than your hips, because that's kind of like riding a tricycle and it's not very comfortable. So it needs to be either straight out or a little higher. So you're up and then just relax. The muscles will work, and because you won't fall off the ball, but those ones can relax and just be soft and do their normal work.
Thank you.
It's the absence of effort.
I just wanted to comment on Kara's question for a moment because I think it's a really good question. We're just finishing up a study actually in Ontario at McMaster, myself and Sinead Dufour. And what we did was we looked at women who come to an orthopedic practice with chronic low back pain because we know there's a lot of studies that have shown historically that chronic low back pain is related to pelvic floor dysfunction about 3/4 of the time. But our question really was, because what physios tend to do is what you're doing, and strengthening their core and giving them Kegels and those sorts of things to do. So what we did, we looked at women who came to an orthopedic practice and we assessed their pelvic floors. And what we found was that 90% of women actually who come to an orthopedic practice with low back pain have pelvic floor dysfunction. So they either have incontinence, prolapse, constipation, pain with intercourse. And that about 83% of those women are over-recruiting their pelvic floors. So the question is Kegels the right thing to do? Is core training the right thing to do in the way that we've typically done it? And maybe, I don't have the answer to this, and I don't think any of us do, but maybe that's one of the reasons that core training, as we have typically taught it through the transverse abdominis, hasn't been all that effective for low back pain. Maybe we're already over-recruiting part of that system, and we need to think about that piece. So that's the first part to that study. So what I tend, because we do teach a course for orthopedic therapists who do not do internal palpation, and one of the things that we do is give them a suggestion to look at some of Eric Franklin's work, which is much more dynamic and less tension producing, and so you're going to get less of that building of tension, but still some work through their inner core. So I hope that helps a little bit.
Or a really nice segue to Todd's talk.
And Todd's talk is excellent, right?
One last question. For folks that are seeing patients that come in and they seem to have some kind of pelvic pain or pelvic floor concerns, if they do not themselves do pelvic floor work, where can they find somebody that they can refer to?
That is great. In the United States, the American Physical Therapy Association has a cleverly named Find a PT option, and we're identified on there. There's a section on women's health that may be changing its name because boys have pelvises too. So you can go there. Canada has a couple different places. I would suggest getting a hold of Carolyn. There's a women's health division with the Canadian Pain Society. The Australians have a great pelvic health, so that's out there all over the world. And the easiest way to do it, honestly, other than all of that, is get on Twitter and ask for the hashtag pelvic mafia to find you someone in the area. There's a great story to why that's the name. But Twitter is a really good way to find someone.
All right, thank you. All right, everyone, please join me in